Hi everyone. So what I'm going to present today is some preliminary findings from a survey that we've done during the early phase of COVID on scientists. So this is a collaborative work with Ivan, Damien, Dave, Ahmed, David, and Benno. So a little bit of background. Assuming you heard of the COVID-19 pandemic and you're aware of the fact that how much pressure it has put on the healthcare system around the world. So basically, medical professionals have been facing this huge challenge of how to actually allocate resources, especially medical supplies. It becomes a triage problem in a sense that which patient should I give priority to treatments? For example, getting the ventilator, access to ICU beds, and so on. Right, so not only this is a logistic or economic problem, but it's also a moral and ethical one, right? For example, you have to think about what is the distribution fairness, justice side of thing, equality side of things, right? So triage is not per se a new concept in medicine, right? If you think about emergency room service, cancer treatments, so there are existing sort of guidelines to this problem in medicine. But then COVID hit, and it gives rise to new aspect in terms of how to come up with triage guidelines with this situation. And for example, early in the COVID, there are bioethics researcher written over this, and largely it goes to it appeals to the principle of utilitarian ethics over this individual ethics, in the sense that trying to deliver the greatest good for the greatest number of patients, right, in order to achieve this public health goal, right? So for example, in this paper published in New England Journal of Medicine, it's quite widely cited, and it summarizes basically there are 4 fundamental values in the sense of how to decide about triaging. Like the first one goes back to the utilitarian aspect of maximizing the benefits of the treatment, right, in light of the scarce resources, by saving the maximum number of lives or maximum number of life years saved, okay, and or in a sense, okay. So for example, it should be treating, say, a relatively healthier person in maximizing the chance of survival because of the treatment. Right, the second fundamental aspect is to treat people equally. For example, if you have 2 patients that have similar prognosis and similar other characteristics, how should you determine the priorities? Should you do first come first serve basis, or, well, in this case, a random lottery is more equal in a sense. Okay. The third one is giving priority to the worst off, in the sense that one of the most example is to actually treat the younger patients, in a sense that because they haven't had the chance to live through adulthood, right? They should be given consideration of this life cycle principle. And the last one is to promote reward instrumental value, in the sense that priority of treatment should be given to those who can save lives afterwards, right? For example, caregivers. So we decided to survey to ask scientists on their opinions. And why do we do that? Because, well, they're part of society, obviously. They are also highly educated, right? They are well-trained in rational thinking, in a sense. And especially with COVID, in times of crisis, their opinions are actually increasingly sorted upon, right? So their opinions are matters to solving societal problems and value to policymakers, for example. Okay, and what we want to actually know is that, well, here is not the right word to use, but do they actually have similar opinions to these triage guidelines that was proposed, right? Or do they actually experience certain behavioral bias when making such decisions? And what are the individual characteristics that's driving this stuff? Okay, so a little bit about survey. It was done during the early phase of COVID in 2020 in May. So at that time, there was already a lot of cases, and there's huge problem with the supplies of ventilators and so all that kind of stuff. And we sent out survey to active researcher across many different fields, all fields to be honest. But in addition to that, we actually oversample social scientists and economists because of their relative involvement in the COVID research in that sense. So in summary, we got about 13,000 scientists who completed the survey. 40% of them are female. Well, age distributions there, 65% of them hold at least assistant professorship. Most of them Europeans and in US researchers. So what we asked the scientists were basically presented two scenarios here, two triage scenarios here. The first one is that, well, suppose that you are managing a hospital in your local community, and there is only one bed available for COVID, right? But then two patients come to you. Which one would you choose to treat? And then in the second scenario, we twist it a little bit differently, where the bed is actually used by patient A. So then your decision becomes whether you reject patient B when it comes later, and discharge patient A in order to treat B. Okay, and participants are reminded to that if you prefer not to make a decision, which they can, there will be some costs, require additional time because of delegation. So we presented 6 options, picked 6 pairs of options, patient A and patient B here, for them to evaluate. So in total, they will have to make 12 evaluation there. Okay, so the first one, gender, second one, age, pregnancy, citizenship, whether the patient has pre-existing health conditions, or the last one, whether they have criminal record. Right? So why are these 6 options interesting? Right? In the sense that if you look at 1, 4, 6, so gender, citizenship status, and prior record, these are what is deemed by bioethics researcher the morally irrelevant consideration. In a sense, right? So and then looking at the second and the third one, well, if you think about the priority to the worst of principle. The treatment should be prioritized to the younger and the female with a baby. And the last one, the fifth one, appeals to this maximizing treatment benefit side of thing because, well, 2 patients differ because of the pre-existing health condition. That treating the healthier patients would maximize the treatment benefit because they have higher survivability in a sense. Okay, so result, what do scientists think? Okay, so if you look at this graph here, if you focus on the orange dots, what you see is that these are the share of decision in the first scenario where both patients come at the same time, right? You see scientists prefer to treat female, younger patients, pregnant patients, and also domestic patients, right? So again, you recall that gender, citizenship, and the last one is actually morally irrelevant in bioethics, at least in the sense. Okay, but what's more important is that if you look at then the purple dots, right? So this is now the scenario where A has the priority and B comes afterwards. So you see a huge shift to A, back to A. So this is what we call first come first served bias, and this is actually strongly opposed by a bioethics researcher, where it creates actually unequal situation. If you think about like this well-documented low SES individuals actually have less access to health facilities. So first come first served basis is not actually equal. And if you think about the second scenario, it's also similar decision into, well, what is the decision of withdrawing life support from existing patient for an evading patient that has great need, for example, okay? So the last picture didn't actually paint the full picture of the story, where you can choose not to make a decision. So what we see here is that decision avoidance is actually larger for those options that are morally irrelevant in a sense, right? Like if you look at the blue bars. But again, interestingly, if you bring in this priority, you see a large reduction in the decision avoidance. So that's interesting in a sense. And when thinking about this problem, we also try to correlate whether it's correlated with the duration of how long do they take to complete the surveys, and we don't find this indecisiveness is correlated with that. Okay, so combining the two, we come up with this picture in the sense that the blue one for each pairs of option shows the first come first served bias in the sense that by choosing B or undecided in the first scenario, you switch back to A. Okay, and we find that the strongest bias here is in gender, right, and the lowest in pregnancy option, right? And we find that this first come first served bias is very prevalent in this case. So a little bit about individual differences. There's still more to go on, but the most striking result here is that if you look at just scenario 1, you see that male participants are more likely to treat male patients, in the sense that there's well documented of this, bias in gender bias in receiving medical treatment. But also remember, the majority of scientists still choose female. But what's more important, if you look at the first come first served bias, this means that the male or female participant actually choose to treat female or prefer not decided in the first scenario. They act like males participant here again is more likely to switch back to male, right? So again, reinforces this gender bias. And another interesting thing is that health scientists are actually more susceptible with this first come first served bias, which is interesting because of the well documented triage problem before in that sense. So there are a lot of other stuff that we are going to do in this survey. Don't have time to talk about it, but yeah, thanks very much.